Hello all, my name is Sarah Dietz and I'm a registered dietitian as well as a graduate student in APN 615. Today I would like to share with you my proposed research design. The title of this study is Reducing the Prevalence of Hypertension Through Adjunct Therapy, Combining Magnesium Supplementation with Nutrition Education from a Registered Dietitian Nutritionist. The basic idea will be that we will provide magnesium supplements to all participants, with half receiving education from a registered dietitian in regards to a healthful diet with an emphasis on magnesium-rich foods. The goal is to see a reduction in hypertension among both groups. However, there should be a more significant reduction in the group with nutrition education. To help refine the focus, the idea of this research proposal began when contemplating the high rate of cardiovascular disease in our society. It isn't a surprise that heart disease has one of the highest mortality rates within the U.S. The numbers are staggering. Cardiovascular disease claims the lives of approximately 610,000 people each year. That's almost 1 in every 4 reported deaths. When attempting to reduce the impact of such a large health problem, you have to choose smaller sections at a time. It has been noted that high blood pressure, calcification of soft tissues, and hardening of the arteries are associated with low magnesium. However, when reviewing the literature, there appears to be a gray area as to the level of effectiveness of magnesium. This author decided to focus upon the role of magnesium in lowering blood pressure levels. It is estimated that 50 to 60% of the adult U.S. population does not consume the recommended daily intake. This intake is between 400 to 420 milligrams for men, adult men, and 310 to 320 per day for women. Magnesium can be found in a variety of foods. It's highest in nuts, seeds, and whole grain cereals. Green leafy vegetables also provide a significant amount in the diet. Magnesium is actually found within the chlorophyll of these plants. Other sources of magnesium can be found within legumes, lentils, spices, seafood, soy, dairy products, and hard tap water. Something that I have found to be very interesting is that there are several different reasons as to why magnesium is reduced in our diets. Some of these reasons include reduced levels of magnesium in processed foods. Common staples in our diet like meat, sugar, and white flour are low in magnesium. Cooking and boiling reduce magnesium levels. Common medications lower the levels as well. And then there are excess losses with magnesium with alcohol use and with diabetes. And there's a reduction in absorption with age, cigarette smoking, and a variety of other reasons. You can see that we have almost engineered magnesium out of our lives with convenience foods and poor lifestyle habits. Magnesium is quite the nutrient of interest. It plays a role within 300 enzymatic reactions, which is rather impressive. Magnesium status can be influenced by several factors, including large amounts of fatty acids, phosphorus, phytic acid, and non-fermentable fibers may decrease or inhibit the absorption. On the contrary, vitamin D, protein, and some carbohydrates may increase this absorption. Once magnesium has entered the body, it becomes a part of those 300 reactions. It is an important factor in energy production through its interactions with ADP and ATP. Magnesium also has a role in muscular contraction regulation, blood pressure, insulin metabolism and glucose control, nerve transmissions, immune functions, potassium and calcium regulation, among others. Magnesium deficiency is defined by a serum level less than 0.75 millimoles per liter. This deficiency level will be accompanied by a variety of symptoms that range from mild discomfort to severe. Initial symptoms of magnesium deficiency include muscle weakness, cramps, spasms, appetite loss, nausea, vomiting, and other nonspecific symptoms. When it becomes more serious, neuromuscular excitability, muscle cramps, tetany, and generalized seizures can be seen. One potential problem with studying and evaluating magnesium is the way in which it is measured. The majority of magnesium is stored within the cells or bone. However, testing is most often completed on serum levels. These levels are not good indicators of body total concentrations. Another form of measurement includes providing an infusion dose of magnesium and calculating the following urinary output of magnesium. However, this is unrealistic for the clinical setting and unfortunate as serum levels may appear normal and the total body stores would be deficient. More time and research should be invested in developing more sensitive testing for the clinical setting. However, this is outside of the current research proposal. A combination of decreased magnesium intake among Americans, cardiovascular problems, and difficulties with measuring magnesium is the motivation behind this proposed study. A meta-analysis of 22 trials found that magnesium supplementation didn't always decrease blood pressure. However, when combined, a decrease was actually seen. There was an overall reduction of 3 to 4 points in systolic pressure and a 2 to 3 point reduction in diastolic pressure. This meta-analysis found that blood pressure levels decreased with supplementation over 370 milligrams per day. Another meta-analysis of 34 randomized controlled double-blind studies showed a decrease in hypertension with magnesium supplementation. This specific meta-analysis was rigorous in the studies chosen and included in their final review. The authors noted that blood pressure reductions were coupled with increases in serum magnesium. A meta-analysis of this nature lends further strong evidence that magnesium can help to prevent or reduce the development of hypertension. Attempting to study a single nutrient such as magnesium can be difficult. You have to consider all the factors that may influence health status. Perhaps this is partially to blame for the number of inconsistent studies that have been published on the role of magnesium in heart health. One review study states that an intake of 500 to 1,000 milligrams per day of magnesium may potentially decrease blood pressure as much as 5.6 over 2.8 millimeters of mercury, or the measurement of blood pressure. However, these results may not be able to stand alone due to heterogeneity. This becomes especially relevant when analyzing the interactions of magnesium, sodium, potassium, and calcium. Not all studies show a link between low magnesium and hypertension. The Framingham Heart Study offspring cohort followed up with participants in 8 years to check for new onset hypertension and again in 20 years for cardiovascular disease. They found no association between the individual's baseline magnesium and hypertension diagnosis. The authors did recognize that there were several limitations, however. A review written by Champagne suggested a stronger association between improvements in blood pressure when consuming magnesium-rich foods as opposed to supplementation. This may be related to, however, the overall change in diet to the DASH, or the Dietary Approaches to Stop Hypertension plan. This diet consists of reducing fat, cholesterol, and sodium while emphasizing intakes of potassium, magnesium, and calcium. This is further driving the need to attempt to pull magnesium out to determine its level of effectiveness. Overall, it has been noted that magnesium is something of an orphan nutrient, meaning that it has been studied less often and with conflicting results. It was noted that a review of 44 studies challenged the current recommended dietary allowance, or RDA, of magnesium. The amount of magnesium found to reduce hypertension without the addition of medication was approximately 486 milligrams per day. This is almost 1.2 to 1.6 times the current RDA. This is simply one other reason why we must continue to research and analyze the role of magnesium. Based on current literature, there is still a lot to know and understand. It is the intention of this study to further examine the relationship between magnesium and hypertension. This author prefers to place specific focus on the examination of supplement replacement alone versus supplemental replacement with nutrition education. The hypothesis of this story will be that adjunct therapy, including both magnesium supplementation and nutrition education, will provide better long-term results in comparison to supplementation alone in relation to magnesium status and hypertension. So the objective of the study will be to further exhibit the RDN role as a nutrition professional and as a member of the interdisciplinary team. In addition to highlighting the RDN role, it is also important to bring more attention to nutritional deficiencies. These deficiencies deserve attention, especially in the day-to-day medical practice outside of a hospital care. The goals of the study will be the stabilization of magnesium through supplements and nutrition education, longer-term success with adjunct therapy and the avoidance of worsening heart disease, further use of the DASH diet for increasing minerals with an emphasis on magnesium, and completion of the study with minimal attrition rate. With approval from the hospital's IRB, participant recruitment would begin within the hospital and affiliated clinics. The participants recruited will be a convenience population. The investigative team would discuss research with office managers, physicians, nurses, and other clinical staff. Copies of the informed consent will be made available for staff and potential participants to review prior to consenting, and this will be done to maintain transparency. Each participant that submits their information must be screened based on the study's inclusion and exclusion criteria. The patient inclusion criteria is as follows. It will be elevated blood pressure with a systolic of 120 to 129 and a diastolic of less than 80, and hypertension stage 1, which is a systolic of 130 to 139 and a diastolic of 80 to 90, and this is defined by the American Heart Association, or AHA, and participants should be between 20 to 64 years of age. The exclusion criteria includes prescription drugs that lower or raise magnesium as a side effect, antihypertensive medications, and diminished autonomy. Strict adherence to these criteria will help to minimize the confounding influences. Individuals who have either elevated blood pressure or hypertension stage 1 are not indicated to receive antihypertensive meds per AHA guidelines. These guidelines indicate that an individual should attempt lifestyle changes prior to medication initiation. This author also chooses to examine the 20 to 64-year age range as a preventative measure of future hypertension. This proposed quantitative study will require approximately 210 people to be recruited to receive significant results, and this is based on a G-power analysis for an a priori independent means t-test statistical analysis. Then this analysis will be run separately for each category for which numerical data will be gathered. So that will be like the average magnesium consumed, blood pressure, and serum magnesium. The a priori independent means t-test was ran with a median effect size of less than 0.05 and a two-tailed design. And choosing this effect size helps to determine the significance level of the proposed study design. So essentially, if alpha is equal or less than 0.05, the confidence level is above 95%. Most studies encounter an approximate 20% attrition rate. So to calculate for this potential loss, an additional 42 participants should be recruited. A total of 252 participants should be recruited for overall success of the suggested research. So our baseline data that will be needed to gather at initiation of study will be serum magnesium, BMI, and blood pressure. The blood pressure will actually be taken twice with a 5-minute rest period, and an average of the two will be used. Data will be gathered at an affiliated clinic of the hospital to ensure privacy. And to further ensure privacy, participants will be matched to an anonymous code that will be kept in a separate, locked cabinet with access only allowed to the primary researcher. Participants will be randomly split into two different groups. One group will receive magnesium supplementation only, and the second group will receive magnesium supplementation and nutrition education from a dietitian. The study intervention will last 16 weeks with biweekly check-ins with their assigned contact. For those in the control group, they will be meeting with a registered nurse, and the intervention group will have a dietitian. Both the nurse and the dietitian will be under supervision of the study physician. This will be done in an effort to ensure that all participants will be free from unintended harm, and if any harm appears to be occurring, the study will be stopped immediately. All participants will receive an oral magnesium supplement of 350 milligrams per day, and this is the established tolerable upper limit by the Institute of Medicine. And they will also be required to fill out a food log for nutrient breakdown and examination. Those that meet with a nurse will simply check in to discuss their progress and to have their blood pressure taken. And those that meet with a dietitian will also have their blood pressure taken, but they will receive education in regards to the DASH diet, with a specific focus on magnesium. And they will receive feedback as the study progresses and instructions on how to improve their current diet. At the conclusion of the study, participants will return to have their serum magnesium drawn, BMI, and proper blood pressure measurements taken. The research team will also progressively analyze participants' intake data and examine the magnesium consumed through diet. Once researchers have obtained baseline, progressive, and conclusion data, the results will be analyzed. All results gathered will be presented in an aggregated manner. An independent t-test will be run to determine if there are statistical differences between group means of average magnesium consumed, blood pressure results, and serum magnesium. This test will run for all three categories described. Measurements of variability, like range, standard deviation, and standard error, measures of central tendency, like mean, median, and mode, and inferential statistics will be reported for each group. If the resulting p-value is less than the alpha value of 0.05 for any of these comparisons, the null hypothesis will be rejected. And the null hypothesis is that there is no difference in blood pressure reduction in individuals receiving adjunct therapy of magnesium supplementation with nutrition education in comparison to magnesium supplementation alone. The rejection of the null hypothesis will allow our data to show that there is a difference in blood pressure when using both the supplementation and nutrition education. This will support the role of the RDN in lessening the burden of a chronic disease, and will also help to support the role of magnesium in the body as a method of decreasing blood pressure. However, with any type of research, there are some issues with limitations, and some of the limitations here is that it's extremely difficult to isolate magnesium, especially when analyzing dietary patterns. Foods are not made up of one nutrient alone, and when changing to something like the DASH diet, you're making overall health improvements. And the study may have a slight bias based on who chooses to participate in the study because they may be looking to become more helpful. I appreciate your time, and I thank you for your attention, and I hope you have a great rest of your day.